Hi, everyone. Thank you for having us. It's really a pleasure to be with you guys at the ACVS CCT India. It's really a pleasure for the University Hospital team to be part of this. We're very excited. We're going to be able to do a case with the newest iteration of Evolut, which is the FX valve, which we're going to talk about the features of the FX. Myself, I'm Attizzani, interventional cardiologist. I'm working with my partner in crime, Dr. Baeza, Christian Baeza, who is a cardiac surgeon. We have Suhan Yoon, who is our structural fellow. Angie, we have Casey, we have Ivan here, and we have Grace outside monitoring our case. I have the whole camera crew, as well as our fellow Shay, who is going to present the case for us, Lena from ECHO. So I would like to start this. I want you to take a look at the setup of the room here. Basically, we have been doing this, the tower in a minimalist approach for years. And we don't have any anesthesia team here in the room. Basically, our nursing team gives minimal sedation to the patient who is fully awake, mostly local anesthesia or very, very minimal sedation. We're going to start the presentation of our case here. Meanwhile, Dr. Baeza and Suhan are working. They're already across the valve there. Just so you know the setup that we have here, we have a 14 French central sheet here on the right femoral artery, which is going to be the main axis. And also we have the pigtail going through the left femoral artery with a jugular pacemaker. So I'm going to hand over to Shay, Dr. Shay Gwebasha, who is our structural fellow, who's going to present the case for us. Shay, over to you.
So I'm going to go along here. So this is our patient, 80-year-old gentleman who weighs 96 kilograms, BMI of 39. He is actually presented to his cardiologist with class 3 dyspnea that progressed over 6 months, no angina, no syncope. His cardiologist was able to auscultate a 2 out of 6 systolic ejection murmur and an absent A2. He had mild lung disease, which did not explain his symptoms, diabetes, former tobacco use. He is also status post 4-vessel CABG in 2010. He underwent left heart cath for his symptom etiology, which demonstrated 4 patent grafts. So you had an SVG to the PDA, SVG to an OM, SVG to a diag, and a lima to the LAD. AFib, he has stage 3 CKD with a creatinine of about 1.5 to 1.7. His other labs are essentially not concerning. Frailty 0 out of 5. His STS prom is 3.2%. LVEF on his echo was 50%. Aortic valve velocity max of 3.9. A peak gradient of 60, a mean gradient of 37. And his aortic valve calcium score was 1800. So given the totality of the data, we're convinced this was indeed severe AS. This is his EKG. You see a sinus rhythm with a right bundle branch morphology. Procedural planning, this was his CT. You can see the reconstructed images of the right and left on both panels. And you see either access would be reasonable. This is his annular perimeter, which measures 79.2, his area 4.68. His sinuses measure 33, 33, and 37. His STJ measures 32 by 31, and his LVOT measures 20 by 27. LVOT calcium is noted on the pre-planning CT. These are our angles we're going to deploy here in cusp overlap. Our cusp overlap view is R1 caudal 30. The coplanar view is LAO 20 cranial 3. The aorta angle is 59 degrees. The membrane septum estimates about 7 millimeters in length. The left main height measures 18.8. The RCA measure 18.9. Remember, this patient is status post 4-vessel CABG with basically his entire myocardium is subtended by those 4 grafts, so not quite relevant. So here's our procedure. We went right IJ access, 7 French sheath for the TVP. Local anesthesia with mild sedation administered by our nurses. The left CFA was accessed for the 6 French pigtail. The right CFA will be primary. We pre-close ×2, 4 French centram. And ultimately we cross the valve with an AR1. We exchange for the pigtail, obtain hemodynamics. We're going to go with the extra small Safari for the LV. And we're going to deliver the delivery system sheathless with the inline sheath. And our valve based on the CT with the Medtronic 29 millimeter Evolut FX. And again, we're going to deploy in the cusp overlap technique. Now I'll hand it to Dr. Attizzani to present the rest of the slides.
Okay, so we're going to use the Evolut FX valve, which is the newest iteration of Evolut. I don't know, I believe most of you know that this valve is just being utilized in the United States by very few centers. We're privileged to have the ability to use Evolut FX here. As you can see on the slide there, that it's an evolution because we still are capitalizing on the supraannularity as well as the septal expandable nature. So all of the features of prior generations of Evolut are still here, obviously. And in addition to the fact that we added there are very important features added to this device. Next, please. So one of the things that this device delivers to us, that we're going to see during the case, is that we have 3 golden markers, which are located at 3 millimeters from the bottom of the valve, which is going to help us understand whether or not we have commissure alignment. That's a very easy way of looking at that, and obviously we can use that for depth understanding as well. Next, please, Shay. In addition to that, you can note that the nose cone of this device is more, I should say, aerodynamic. I don't know if that's the best word, but it's not as bulky as the prior nose cone, which basically facilitates 2 things. When we go on in the femoral axis, it makes it easier for us to go in addition to the fact that it's much easier to go through the aortic arch with that as well. In addition, one more important feature of this device is that it has only one spine. If you guys remember, when you get your Evolut, your Pro or Pro Plus, right? You have 2 spines. So one of the sides is very hard and it bends very easily if you rotate the device. In this case, it's much easier because there's only one spine, which makes it much easier to go across the arch, right? Combined with that nose cone, it makes it much easier to go across the arch. And finally, a very important feature of that single spine is the fact that it also enables us to deploy the valve more coaxially. I'm sure that a lot of you guys in the audience and in the panel, they have had situations in which you have either horizontal aortas or when you are biased in the inner curvature of the aorta, that you have an uneven deployment. So this device came here to address that prior limitation of the prior generation of devices. We actually did have a call this week discussing the centers that are doing this. I think we all have this understanding. We all have this feeling that that is indeed much better right now. And another observation, and we're going to see during the case, is the fact that when you are deploying this valve, the valve tends to dive less to the ventricle. It's a more stable deployment overall. And then going back to Sushil's comments on the wire, we are using Safari, which is our workhorse wire, and we believe it works extremely well with this device. So we're going to use the Safari wire today. Next, please, Shay. So this is just what we're going to see now. What you see on the screen there, it's easy for us to understand whether or not we have commissure alignment. We're going to have 2 dots on the left-hand side of the screen and 1 dot on the right-hand side, or even distribution of the dots when you look in cusp overlap to understand whether or not we have commissure alignment, which is being discussed, the commissure alignment on prior talk. We were listening to the talk there. Next, please. Next, please. This is just one example of one of the cases that we've done in the past. You see 2 dots on the left, 1 dot on the right, which indicates commissure alignment. Next, please. And which was confirmed when we did a CT post study. The commissure alignment, as you can see on the screen, has been confirmed that that's indication. What we saw on the angio after the case is actually confirmed that we have great commissure alignment post deployment. Next, please. Just the final slide before we go to the case is that this patient we have on the table right now, this is based on our data. You can see on the screen. We're going to have a talk on this later after the case. But basically, this patient, right, he has a 7.5 risk of pacemaker. He has a prior right bundle. If we go either 3 millimeters or less in terms of depth, or I should say less than 3 millimeters, and if you go between 3 or more, the risk of pacemaking increases to up to 30%. So we're going to try to be precise, minimize interaction with the conduction system to see if we're going to be able to basically deploy the valve without any conduction issues. Okay? So any comments from the panel?
No, we're very excited to see this, Dr. Attizzani. I mean, I've played with this outside the body, but I've not seen it being deployed. So, and I think the commissure alignment is something that we are getting more and more recognition and on how important it is for a variety of reasons.
Great. Excellent. So we're going to move forward if there's no further comments from the panel. We're going to move forward here. So as you can see on this, can you see our screen there well? Everything good?
We're still seeing the slides, so we might have to switch to the screen now.
All right, let's switch to the screen. Can you see the screen now?
We can see you, but not the split screen yet.
All right, guys, can you see it?
We can see the screen.
Excellent. Okay, so as you can see, we have our pigtail in the LV. We already did pre-procedure hemodynamics, which, as we know, is extremely important. As we don't do TE, right? We always combine the assessment of hemodynamics and transthoracic echo after the procedure to understand the quality of our results. So that's very, very important for us. The EDP of our patient was low, so we're hydrating him. Remember, he has kidney dysfunction, and therefore, we don't take any pictures. So there's no pictures that have been taken so far. We don't take a picture in commissure alignment. We don't take a picture in coplanar view. We just do the CT planning and we go for it, right? So we're gonna use minimize utilization of contrast. If we are happy after the case with echo and hemodynamics, we also do not do a final aortogram because that does really not add too much value to the case. And again, we want to minimize contrast utilization here. Okay, so before we take the 14 French sheet out, it is important, one mention is that we always go with a 14. Some people tend to go with a smaller, like 8 French or 10 French sheet, which I believe really doesn't make too much sense. So we always prepare the vessel. We go with a 14 if we're gonna use a 23, 26, or 29 valve, which we did. And we're gonna, he's moving his hand. And we're going to take the sheet out and go sheetless as we do in most of our cases. We did also check under fluoroscopy. We checked that the valve is properly mounted on the catheter. We're happy with that. And we're ready to go in with the device right now. Any comments from the panel?
No, I mean, that seems like a very solid technique and very standardized.
All right, going in now. So we're gonna take the 14 French sheet out. So 14 is coming out. Hold on. Valve, please. All right, so now going in with the valve, making sure that our flush ports are located at 3 o'clock to increase the likelihood we're going to have commissure alignment. Photo, please.
So if you don't see commissure alignment, are you actively pulling back into the descending and rotating again, or not?
That's a very
also, yeah. Go ahead. I'm sorry.
No, that's a very important question. So the answer is depends, right? Depends on the patient that we have, right? In this case, our patient is grafted, right? He's fully grafted, so he has grafts. So therefore, if we do not see commissure alignment, we're not gonna come down to the descending aorta to rotate. We're gonna take it whatever it goes, right? We have done, just one second, we have done here close to 30 cases of FX, and in 99% of the cases we had commissure alignment by going with the flush port at 3 o'clock. There was only one single case that we did not have it. So we expect that we're gonna do it, but I think that's a very important question, right? If we do not have a commissure alignment, so should we go ahead and come back to the descending aorta and turn? If the patient is a young patient that we may need to have access to the coronary, our patient that has coronary disease, coronary artery disease, right? Then probably we're going to come back down to the descending aorta and reorient our flush port and then try to achieve commissure alignment. But that's a very important question. And because this is a limitation, right? Then the next generation of this device is going to likely come with a rotational mechanism that we can actually perform commissure alignment while we are in the ascending aorta, which is going to facilitate our lives in that regard. But thanks for the question. It's a very important question. Any other comments from the panel?
No, why not do it routinely? I mean, if the arch is not hostile, would it not make sense to use the technology? Because I agree with Sushil that it's not going to translate if you turn it in the ascending aorta, especially with one less spine. So I know there was a period of time 3 or 5 years ago when we would routinely bring it back to adjust the hat marker because we felt that that gave a more symmetric expansion. And so I'm thinking back to that era, and it wasn't a big deal. So would you consider just doing it in every case?
Yeah, so again, we go with the flush port at 3 o'clock in every case, and 30 cases, close to 30 cases that we've done with FX, we have seen commissural alignment in all of the cases but one, right? Obviously, we do it all the time. In every case, we put the flush port away from us to increase the likelihood of commissural alignment. I think my point was, in this case specifically that we have, this patient we have on the table today, right? He is fully grafted. If we do not have commissural alignment when we cross the arch, we're not going to come down to the descending aorta to rotate the spines, because obviously the more manipulation you have in the arch, the higher the chance of stroke and other issues, right? So in this case, particularly, if we do not have commissural alignment, we're going to just accept whatever it comes. That's the point.
Makes sense.
Okay, so we moved the camera already to LAO to open the arch, and we're going to cross the arch now, making sure that the flush port stays at 3 o'clock. So Chris is going to push now. Hold on. How easy was that to cross, Chris? Smooth? We have noticed that this device, right, it makes it much easier for us to cross the arch. When we have, very ungulated, very horizontal aortas combined with very calcified arches, it's still going very good. The nose cone and the single spine really makes it easier to cross. Okay, hold on one second. Yeah. Can you move the protector out of you? Okay. Move more, Chris. It's gonna hit that. Take that out of the way, please. What is the FFR happening? 18 total, 32. 32? 32, yeah. No area. Understand. All right, so we're going to the cusp overlap projection right now. We're gonna mag up. All right. I have the wire.
So the head marker already showing us that we're going in the right direction. So
Yeah.
fast forward.
Go. Push. All right, so we're gonna go. Another important aspect of this device, we were hearing the talk prior to our case, is that normally for when we do cusp overlap, right, we start halfway through the pigtail, and what we have noticed with this device is that we are starting a little lower because it dives less, right? So we are starting a little lower than we used to start with Evolut Plus, please. All right, so pigtail is in the right spot. And we have no parallax in cusp overlap view. And we're happy to start deployment here. We're gonna go up maybe a little bit deeper because again, this valve is not diving as much as the other generation used to. All right.
One question to you. Do you use some fast pacing for stabilization of the system?
Yes, we're going to pace. Yes, we are going to. We always pace 100% of our cases, girlfriend. So Suhan's is starting to rotate just like we do. Same story for compare with Evolut Pro Plus. So quick rotations at this point. Fuck. Push more, Chris. No, pigtail is good. Push more. A little more, really nice. So we're gonna, as I said, start a little lower because we noticed that this valve dives less than the other generation. Puff. A little more. Yes, that's good. Don't hold the time. Yeah. Mini puff. Pigtail is good. Chris, a little more. A little more, Chris. All right. You guys can notice the 3 millimeter mark at puff. Good.
Pacemaker on 140.
Pacemaker on 140. Puff. Well, well. Put 10. Well, put 10. Put 10. Puff. Good stuff.
Pacemaker off.
All right. Vocine. Inject.
Inject.
All right. Good. So we took the first picture in cusp overlap, which looks good. Now we're going to go to LAO. Flora. Flora. All right. Make sure we don't have parallax in LAO. All right. Ready? Cine. Inject.
Inject.
All right. Happiness or frustration from the panel?
You know, that looks like a beautiful depth. I mean, and the control, it seems, obviously you're a very skilled operator, but it also seems that the control on this is even better than the previous generation device.
Yeah, I agree. I think we all agree with that. So I think we're happy. Chris, are you happy?
Very
So
happy.
it's a horizontal aorta. You know, compared to the prior Evolut, it seemed to centralize more. Is that what your experience has been? More so? So similar to like a portico, it does sort of centralize a little bit better without the
Yes,
second spine. Is that
that's a very important question, Sushil. Yes, we have noticed that it does do it. It has a much more coaxial deployment, Sushil. In fact, you can see in this projection, right, that it's even.
Yeah.
The depth of the valve is very even. So yes, we have noticed that. So now we're just going to deploy the valve here. So Chris is going to do forward tension, right? Forward tension to take the tension out of the system. As you could see, basically Suhan pulled the wire all the way inside the nose cone. So the wire comes all the way out of the ventricle, right? And we're going to start pacing the patient. We pace for final deployment 100% of our cases. Pacemaker on at 140, please.
My question is, if you have three features simultaneously going on, one is your cuspal alignment, commissural alignment, and central alignment, do you think this FX valve meets all three alignment perfectly? In how many cases you go for 100% perfection? Or is it just an imagination that you are doing in all three parameters?
Just 1 second. Let us just deploy here. Stop. So I want you to pay attention to what's happening now. So basically, we do all of our deployments. So Chris is doing forward tension. We're pacing the patient to have an aortic pressure, systolic pressure around 90, high 90s, low 100s. And Suhan is going very slow, letting the valve really expand progressively, right? To prevent the valve from moving. So we go very, very slow. Chris, more forward. We go very, very, very slow in our deployments, right? So we take the tension off the system progressively.
Why you don't remove pigtail? I saw some in such
We
situation.
never remove the pigtail, never. The pigtail never moves the valve. We can, I always make a joke with my fellows that, okay, so we're gonna, 1 second, Chris.
What is the benefit to let pigtail in this distal position? If you remove, you could even provoke some dislodgement of debris and provoke some stroke. I saw
1
such
sec.
case.
All right, pacemaker off. Just 1 second. I'm going to address. So we never remove the pigtail. Never. I always make a joke with my fellows that you can close your eyes and pull the pigtail. It's not going to move the valve. This patient, again, I'm going to rely on my procedural planning, right? This patient had very wide sinus, wide FTJ, So I have no concern whatsoever with keeping the pigtail there. The reason why we keep it is because it still is a landmark to us, right? So we keep the pigtail always, 100% of the cases. We don't use a wire to pull it out. You just pull it out, and we are very comfortable with that, right? So I want you to pay attention to several aspects here. Number one is that there's no conduction disturbances. And per the data that we presented prior, right, we still have 7% risk in this patient that we're gonna have need for pacemaker, although there's no conduction disturbances whatsoever during the procedure. Therefore, for patients in whom we have prior right bundle, he's gonna go to the ICU or to the step-down unit with a temporary pacer and we're gonna observe him until tomorrow. We've been very liberal pulling pacemaker out for patients who do not have right bundle prior and no conduction disturbance during the procedure, but we do keep in this case because there is a small chance that he may have a late conduction disturbance, right? So we're doing our echo now. So Lina is ready there. So we have our echo team is always very well, trained, and they are. She's doing the echo right now. The windows are not great here, Lina. So Lina telling us there's no effusion, no PVL. We have a routine. We go long axis, then we transition to the short axis, as you can see there. Supracord here.
So far it looks perfect.
Yes, so we're gonna do our apicals now. So Lina is gonna do an apical view. The windows are not great here. So obviously we're gonna do a hemodynamics post-procedure as well. It's very, very important. We really rely on the results. We gave 500 cc's of fluid to our patient because his EDP was very low in the beginning of the procedure. All right, the 5-chamber there looks great as well. There may be trivial paravalvular leak there close to the mitral inflow. What is the gradient, Lina? All right, so we're gonna get a gradient. All right, excellent. Our patient is awake. He's interacting with us. Can you ask if he's okay there, please, Ivan? Almost done, Jerry. Okay, so gradients look great as well. We're gonna finalize now. We're gonna go with a 3-chamber view. And if we're happy with that, we're going to do our hemodynamics and across the valve. Again, another important aspect here is that some people take the inline sheet out and they put a sheet back in to get hemodynamics. It's absolutely unnecessary, right? We are gonna get the hemodynamics through the side port of the inline sheet. Another aspect to consider here is that the hemodynamics is very, very important. So we just pull basically what we do. We pull the pigtail as you saw, right? We're gonna recross with the same pigtail, and then we're gonna get the hemodynamics from the side port of the inline sheet. If we're happy, then we're gonna be done with the case. Again, we do not take aortograms routinely, even more so in this case, because the patient has kidney dysfunction. And honestly, the aortogram does not add any important information to us. Unless we have a discrepancy between the results of the echo and the hemodynamics, meaning echo shows trivial or no PVL, but EDP goes much higher, then we're gonna do an aortogram. Otherwise, we don't. So we minimize contrast utilization for these patients. So this is very, very important, right? Okay, so we're already across the valve. We're zeroing now the blood pressures. Yeah, you can see we're zeroing now. Can you zero, please?
May I just ask you once again, so if you don't perform final angio, so once again, your favorite is echo, right? Then hemodynamic measurement. If you have discrepancy, you do angio, right?
That is correct. If we do have a discrepancy between the results of the echo and the hemodynamics, then yes, then we would do. Did you guys cross the valve?
Sorry to ask again, discrepancy, it means, what do you mean discrepancy?
Discrepancy means if we have no PVL or trivial PVL, right, on the echo, but there is a significant increase in the LVDP after the procedure, then we're going to do an aortogram. If there's no such a thing, if the ADP is stable, right, and it's concordant with the result of the echo, then we were done. Then we do not need to do an aortogram, right? We also, in addition to that, we do not do angiogram in the peripheral vessels. If we put the proglides down and there's good pulse, no bleeding, we're done. We do not take that picture because that picture, again, does not add any significant information to us. We have not been taking aortograms and peripheral angios for many years here. So we do not usually do that.
Thank you, Dr. Attizzani. This is Dr. Srinivas Kumar here. This is what I really liked about your approach. You balanced approach where echo and angio together are used optimally to give best results to patients. I've seen many operators talking about cuspal overlap technique also, but I see your passion in doing it in 100% of cases. I think that's why we requested you to share your experience of this and conduction disturbances avoiding after this also. But really appreciate your passion in this cuspal overlap technique. Many of the operators whom we asked across the world, they say they do use it and they check it in other views. But you are very passionate about this, and I think that's how you could demonstrate the results being well. One word I wanted to ask, you always wait for these 5 minutes. Some operators say it is not required that much. But if you give some time, I think valve will expand better and oppose better to the annulus to avoid complications. That's why you always make it a point to wait for 5 minutes or so, checking everything and before you release it?
No, so that's a very good question. So before the final deployment, we do not wait for 5 minutes because the valve, at that point, the valve is still connected to the catheter, right? So there's not going to be any further expansion of the valve when it's connected to the catheter. So if we are happy with the depth of the valve, right, then, and again, relying on the procedural planning that we know that we pick the appropriate valve for that patient, we do deploy. We don't wait for 5 minutes with the valve connected to the catheter. That's, to me, to be honest, I don't think it makes too much sense because, again, the valve is connected to the catheter up top, and it's not going to further expand in the bottom, right? What we do, though, is after we do the final release of the valve, if we have PVL that is more than mild, then what we would do is to wait for 10 minutes and redo the echo because the valve is further expanding, and then we're going to reassess the needs to do post-dilatation. So that's what we'll do. But we do not wait with the valve connected to the catheter. We do not wait with that to decide anything.
So basically you're waiting here and assessing the hemodynamics. That's why you're not releasing yet. Otherwise, you're happy with the valve, and then finally you release it after everything is done. That's what you don't personally wait per se, but you're just taking time to check everything is all right or not. That's what you mean. Right. Thank you.
Correct. Yes. Thank you.
So if you were in the cusp overlap, and a lot of times, especially by cuspids, you see a lot of asymmetry. We didn't talk, obviously, the role of pre-dilatation, but say you pre-dilate or you don't, and you're asymmetric. Do you try to be a little bit lower, or do you take it out and balloon the valve first? I always worry when we're really high at zero about the ability to post-dilate and the risk of popping up on one side. How do you approach when you have asymmetric deployment?
That's a very good question, Sushil. Thank you for asking that. So basically, we actually predilate a lot our valves. This case specifically, we didn't think there was a need for predilatation, but we predilate around 70% of our valves. As you know, in the US, it's around 40% predilatation with Evolut nowadays, and we predilate much more than the national average because we aim at avoiding post-dilatation, right? So it's clear that when we predilate more often and more aggressively, I should say, we reduce the likelihood that we're going to have the need to post-dilate, right? If we have to post-dilate, obviously, we would post-dilate, but being careful and understanding that there's always a risk of the valve moving up. And as you said, Sushil, we take it into account, right? Sometimes for some bicuspids, or sometimes if it's a very heavily calcified valve, yes, let's implant this valve a little bit deeper because there is a higher likelihood that we may need to post-dilate, and therefore we want to be on the safe side. Yes, we do take this into account. It's a very important question, Sushil. So we do do that. And pre-dilatation for bicuspid, I know that in India, the prevalence of bicuspid valves is very, very high. And we pre-dilate 100% of our cases for bicuspid. We only use 3 dilatation balloons because they go up and down very quickly, and they rarely watermelon seed. So we prefer to use 3 dilatation balloons, obviously taking into account that the planning needs to be done appropriately because we want to avoid having issues such as, anal rupture or things like that. But that's a very important question.
This accurate neo, they have now these alignment markers, and you have these FX valves without alignment markers. So if you compare the FX versus accurate neo, the alignment of the central and the commissural alignment will be much higher with the accurate neo. It will be as good as accurate neo.
So I think I haven't used FX yet, but I have seen it in development. And I think this is incremental.
Incremental.
It's evolutionary and not revolutionary.
Right.
So it takes, I liked it. I think Harold Dorman, who's at University of Vermont, he did a couple of cases and he posted on Twitter that a couple of steps forward and no steps backwards. So we think this is a progress. So I'm looking forward to doing our first cases in a couple of weeks. No, this was fantastic. Let me ask Sushil. Sushil, in general, what percentage of your cases are you pre-dilating? Because my philosophy is pretty similar. I would much rather pre-dilate than post-dilate, number one. And I do think that the expansion of the valve is more symmetric with a little touch of balloon, and that perhaps that has implications on long-term halt.
It's a good point. I mean, maybe we should be more aggressive. I mean, I think bicuspids, we always pre-dilate. Heavy calcium, we do. We're not quite at 70%. I would say we're probably more in the 30 to 40, which is, I guess, more in line with sort of national averages. But it is a good point because we do post-dilate. We see this asymmetric thing that Dr. Attizzani was talking about, and we end up post-dilating. So I wonder if we were more aggressive with the pre, we could potentially avoid that. So it's something that we got to think about.
If you just to make one comment, I would like you guys to look at the screen here to see this. I don't know if you can see appropriate. Can you try to zoom the screen here so everybody can see? I want you to see the 2 golden markers on the left-hand side and one on the right-hand side, which is indicating that we have commissure alignment in this case. So this is a very important, aspect of this. So you see 2 golden markers on the left, 1 golden marker there on the right-hand side, showing that we have commissure alignment. We're going to confirm that with a non-contrast CT post. But that's one beautiful feature of this device that enables us to understand that in a very easy way, whether or not we have commissure alignment.
Dr. Attizzani, I think we should congratulate you. I was told that this is the world's first live demonstration case of Evolute FX system. And not only colleagues in India and South Asian countries, but many colleagues even in US are logged in Zoom platform, I was told. Congratulations, and you have highlighted some of the important aspects of the new system in the deliverability as well as the markers which are there, which help in precise placement with commissural alignment. Great, and we are about to finish the time. Any final words to conclude your case? Then we'll have your presentation of 10 minutes on how low or how high to place for decrease conduction disturbances, that talk. Any final words before you close this live case?
No, I just would like to thank you guys for the opportunity. Thank you, all the moderators of the panel for interacting with us, for asking very important questions that I think this was a great case. I'd like to thank my team that is here. This is like I was talking to the team, because there's a regular case that we do it every single day. We didn't change anything for the live kids. It's our routine here, basically. So I'd like to thank everyone for the opportunity, and we look forward to the next live case. Thank you.
Thank you, sir. Great demonstration.
Thank you so much.
Round of applause to him from
Saurabh,
all the hall here.
How much?
Thank you. Would you
what
like-
degree of non-alignment is an acceptable non-alignment on post TAVR CT?
I think
angio?
if you're done with
What
the case, can we have your lecture, Dr. Attizzani, now? We can continue with the same link.
Okay, so,
Yes,
so a couple
absolutely.
of comments from the panel.